Okay, so this was a paper from 2008 where they talked about the significance, the correlation between a positive discogram and signal on an MR examination. Now, for years, the definition really of discogenic pain was uh, pain in the lumbar spine that's exactly reproduced by doing a discogram. And with a discogram, you stick a needle into the side of the disc and then you inject contrast. The most important part of it is when you increase the pressure with the contrast, if that reproduces the pain, then that's a positive discogram. People also look to see whether then the contrast in the center of the disc extends through a tear out into where the disc extrusion is or protrusion is, which would confirm that you're dealing with a herniated nucleus pulposus. But the important thing was actually the patient's symptoms, and it was thought that you had discogenic pain if the discogram was positive as a source of the same pain. There's debate about just how accurate that is. And one of the problems with doing that at that time, and several decades ago when it was very popular, the treatment at that time was a discectomy, which turned out not to have very good outcomes. So that whole concept of discogenic pain led to uh, uh, surgery and not very good outcomes on surgery. We'll talk a little bit more about that later. So I think people have talk a lot less now about discogenic pain. And in fact, right now it's generally considered that if all you have is back pain, unless you have an infection that needs surgery or something, that back pain that does not radiate into the legs is typically not considered an indication for back surgery unless you have instability or some lesion that surgery can really correct. That it doesn't really correct discogenic pain or degenerative pain on the spine. We'll also talk about some of the data concerning radiculopathy as well, where there are a lot of things that have become under question. But this just actually looked in 2008 about signal intensity on an MR examination, how much hydration there is in the disc, and how frequently you got a positive discogram. And so what they found is that if the disc was normally hydrated, you very rarely got a positive discogram. So if you have mild, moderate loss of the disc, which is very common in all middle-aged individuals, then a positive discogram was quite common. And then you commonly got a positive discogram if you had severe signal loss. But it's felt that severe signal loss there weren't any good treatment options. So what you really look to do discography are in those patients who have a moderate loss. And we'll talk a little bit later. Discography is pretty much not done anymore for reasons we'll talk about probably later in this talk. So they felt the most useful was when you have moderate signal loss with the discogram. I don't believe that that's the appropriate way to manage patients anymore, but there are people who disagree with me. So here's a study where they actually looked at the risk of discography. That's the one I'm thinking about. This is from Karaji, which is a year later than the previous paper. He's a neurosurgeon from Stanford, and he's done a couple of really good studies. This one, he took 50 patients with 52 matched controls, and then went MRI and discography back in 1997. So there aren't very many surgical cases or interventional cases where you actually have control groups. And control groups really are really important. After 10 years of follow-up, they repeated the MR scan in 2007 and looked for any changes in the degenerative disease of the disc in the discs, and if there are any new disc herniations at that time. And so what they found is, that in the disc where they did the injection, there was a statistically significant decrease in height and decrease in signal loss. Now, it could be that this was just a disc where they might have been abnormal to begin with, and therefore is going to degenerate faster. But the other thought is that the discogram itself damages the disc and leads to degenerative disc disease. And the other thing he found to go along with this is that there were new lateral disc herniations on the same side as the puncture in the discs that were punctured, and there were no lateral disc herniations in any other discs. So it's now widely believed that discography damages the disc, and also because you damage the annular fibers, it can lead to new disc herniations, which can lead to loss of the normal biochemistry of the disc and then lead to degenerative disease. So this was kind of a death knell for discography that had been coming and going every few years for decades before that. But I see very, very little discography now. And his conclusion was that there's a need for non-invasive replacement for discography. And I'm going to talk about some things that we worked on that time, which was to use the MR spectroscopy to evaluate biochemical changes in the disc in a few lectures from now. So let's go on and talk basically about imaging of disc disease. This basically comes from, this is from previous ASNR website, but it's really nomenclature that came up with a number of different societies who met under the auspices of the North American Spine Society to come up with a nomenclature for disc disease. Michael Brandzawanski down in Orange County a few years before this published a paper showing that there are 50 some odd synonyms in the medical literature for disc herniation, which he claimed caused a lot of confusion and unnecessary confusion that led to poor ability to compare different studies because of different nomenclature used. And there are a lot of people who felt that that there was a lot of that confusion was kind of on purpose to maintain spine surgery. So disc disease. So you can look for the nuclear signal intensity. That's the degree of hydration within the disc, which we'll talk about. Now, their nomenclature is a herniation, and at this particular time, many of us in radiology were trying to get rid of the term herniation because we thought that that biased people too much towards surgery. But they state that any protrusion of the disc beyond the normal contour of the cortical margins of the end plates of the vertebral bodies above and below it should be called a disc herniation. And then you can further characterize it to help determine the significance. We'll talk about protrusion, extrusions, and then if you have just a degenerative disc, you tend to get a diffuse disc bulge. So we'll talk about this in more details. And if there is a focal herniation, then you should look at its location, its size, whether it compresses the nerve root, and then we'll talk about postoperative MR later. This is from the same website, so we look at morphology. And then once you see a disc herniation, you need to see whether it's contained, whether the entire disc herniation is continuity, its relation to the posterior longitudinal complex, the volume, composition, and location. So this is kind of what a normal disc should look like. And one thing to notice here is that the normal disc does bulge out a little bit, circumferentially all the way around. There are some people who kind of overcall disease, which would call this a disc herniation when it's just the normal contour of the discs. When you start getting an annular tear, as we saw in some of the histology slides, you can start getting the nucleus pulposus to extend out into the Sharpie's fiber and the annulus, and then it can protrude out outside the normal confines of the disc and the normal confines of the vertebral body interspace here, where it's a true herniation. And this is what that looks like. This is a cadaver. We can see an injection of contrast. This is that tear through the annular fibers and Sharpie's fibers. Here's what it looks like in the gross specimen when you section it. This is the tear coming back. And then you can see these fissures within the substance of the disc in the area where you have the tear. Further studies, this is an MR examination showing this phenomenon in a cadaver. And here we can see what the gross specimen looks like, showing that tear of the annular fibers. These are the Sharpie fibers here, the annulus there, and focal disc protrusion coming out here. And there you can see where the nucleus pulposus can herniate out into this area. Now, in people my age, there really isn't nucleus pulposus. Most of it is dried up by that particular time. So true herniated discs in terms of nucleus pulposus are typically in middle age or younger individuals. And we'll talk about why that may be important. And here you can see the gross specimen. There's that tear. And then as you go further, you start losing the substance of the vertebral body, and you can get a marked loss of the disc, and eventually the disc will go away. You'll have direct bone-on-bone articulation as you get more and more degenerative disease. And you get clumps of regenerating chondrocytes here, and you lose the normal number of chondrocytes you would see there. Now, starting in a bunch of changes that we can talk about. One has to do with annular tears or annular fissures, which I'm sure you've all read about. These are areas of high intensity zone within the annulus, typically posteriorly here. In fact, the North American Spine Society recommended calling this a high intensity zone. And many papers have suggested not to use the term annular tear, even though histologically this can be associated with annular tears. But an annular tear, many people believe, is too suggestive that it might be a surgical lesion. And most people believe, as we'll talk about, that these are an indication of degenerative disease of the disc, and surgery is not proven to be helpful in treating degenerative disease of the discs. Other people call it an annular fissure instead of a tear, primarily just to connote that it's less likely to be a surgical lesion.
One of the problems is the HIZ represents a trauma, and lawyers love it, and I think that's why that was eliminated.
Yeah. So it can lead to unnecessary surgeries, and it also can lead to inappropriate financial judgments in the court, right? And so the North American Spine Society suggests using the term high intensity zone. And histologically, this is areas of vascular, when it's chronic, it's vascular tissue, granulation tissue, or it also earlier on could be an annular fissure. But they strongly recommend not using the term annular tear. Also, most studies show that there's very poor correlation between high intensity zones and the presence of recent trauma or a painful disc. So the only thing it really indicates is that you're dealing with degenerative disc disease, but it can be associated with other things. So this is just information here. Let's see. Jason, what do you think here on this study?
It looks like there's a broad base disc bulge with asymmetry to the left with some high intensity zone in the left pericentral
You
region.
can see there's a little bit there. Personally, I wouldn't call this a bulge. I think there's a little bit of loss of signal, so there's a little bit of desiccation. So I think there is some degenerative disc disease here, but I don't think that this degree of bulging is abnormal.
Okay.
So,
I'm not sure that's a bulge either, John.
yeah.
And then not the discs are not perfect in their circumference.
Yeah. Okay, so this is on 3/9/2004. The patient came back 3 years later, and this is what that same area looked like. What do you think?
Okay. Well, that high intensity zone has definitely increased in
Yeah.
size.
And I don't really think there's much of one there before, but yeah, it's very subtle maybe. And then now you could see that it's much more prominent. There's decreased height of the disc there, a lot more desiccation in the disc, and maybe a little tiny focal protrusion here, but it's a millimeter or less, so it's I wouldn't call it that.
Okay.
So this is basically the development of a new annular fissure or a new high intensity zone, but it's heavily associated with desiccation and loss of height from the disc. So this is really a signature that you're dealing with degenerative disc disease.
Well, this does not affect the nucleus pulposus. This is strictly the fibrosis.
Right. And histologically, the nucleus pulposus is really completely dehydrated here. Histologically, in this particular setting, I'm sure this is going to be granulation tissue, vascularized granulation tissue. Okay. Okay, Robert.
Okay. So we have two sagittals of the L spine to evaluate for central stenosis.
That's what they did the MR scan for.
Uh, I mean, I don't see any high-grade central canal stenosis. Looks like a disc extrusion almost at L5S1 with.
A little high intensity zone in it.
Mm-hmm.
So this is a little high intensity zone annular fissure on 8/10, 2016. Now let's go back a year and a half earlier. This is what that area looked like.
Yeah. So it looked more like a disc extrusion, and I don't see that high intensity zone, but
So that's a focus.
I'm not sure that's an extrusion. It's a protrusion, maybe.
So here we can see, okay, so there we go. Let me see. So here's what it was before. Here's what it was a year later. So, and at this time we had the high intensity zone. So what this shows, most fissures are actually probably scars from old protrusions.
That was a
That doesn't show that this was non-operated on. This was one case. It doesn't mean that all of them are that way, but at least in one case, we could see that that high intensity zone was in an area where there was a prior resorbed protrusion. We'll talk about disc protrusion resorptions too. Okay, Elior.
29-year-old MLB pitcher, vague right back pain for a week. Then severe pain extending to the SI joint. Kind of in the upper lumbar spine, we see a disc protrusion causing some moderate spinal canal stenosis.
Yeah. Okay, here are the axial images.
Yeah, it's affecting the right lateral recess.
Right. And right into there, and we can see that there's high signal intensity, so it's a little focal high intensity zone. In this particular case, this was more of an acute injury where you have high signal intensity there as well. But the vast majority of time, these are chronic lesions, not acute lesions.
Okay.
all right. So we have two T2 sagittal images of the lumbar spine 3 years apart. So it looks like we have two disc protrusions at L45 and L5S1 with some high intensity zones. And I think the high intensity zones look more conspicuous on the follow-up, right? They're kind of larger.
I don't know.
I don't
They're slightly different exact
Yeah.
locations where the cut is. The bottom line is that they're there both, and there's not a whole lot of change in the two. And looking at a lot of high intensity zones in patients where you have prior studies, there is a little bit of central stenosis here. It's most commonly these lesions are stable for years and they don't really change appreciably. So this is the norm, not the exception.
Okay.
But we've seen them develop, like we just saw. I've also seen them go away over time as well. So all things can happen. Okay.
So we have a 50-year-old with low back pain. Looks like at L5S1, there's a high intensity zone.
Okay, so this is 10/20/2007. Here's a couple of years later.
I don't see that high intensity zone anymore. So
Well, I know it's there, but it's not as bright as it was before. So this is one that got better over time. And if it's scar tissue and granulation tissue, then you could expect that it could fibrose in and kind of go away, which I think is what happens.
Okay, 49-year-old male attorney with back pain after an automobile accident. Yeah, so 5, 4, 3. So L1-2, we see some uh, increased signal intensity and that, yeah.
Now, high intensity zone. This was on 1/10/2003.
Mhm.
Here is 12/18/2007.
Yeah, so it seems stable on the right, maybe on the left, a little increased.
Okay, maybe another level evolved here, a little worse. So there's a little bit of progression of degenerative disease, but the high intensity zone is pretty stable. So this is 2007. It came back again in 2009. This is what it looked like.
Yeah, I'd say it looks pretty similar again.
Maybe a little bit more protrusion, but
Okay.
a little bit more, but not much. Okay, that's a 10/7/2009. See, that's, oops, sorry. There we go there. Maybe something sitting there now. The next cut over look like this.
Okay. Yeah, so some, huh. So spinal, well, and the axial, that's the the axial at that level.
There's
Okay.
another root.
Uh-huh.
And then there's this that's going right through here.
Yeah. Could that be some protruding disc?
Yeah, so I think that's an interval disc extrusion. And it's right in the foraminal zone. And this is right where the patients fit with their symptoms. So I do think that these areas of annular fissures may well represent, well, I think it represents abnormal annular tissue. It's probably, well, histologically, at least in some of these cases, it's granulation tissue. It probably is a persistent weakening if it doesn't completely fibrose down. And in this particular case, this patient developed an extrusion right through the chronic annular fissure. I haven't seen very many of these happen, but it probably is an area of weakening. Okay, so what do we know about annular fissures? There have been a lot of papers that have looked at annular fissures. Generally, they're stable lesions without progression over years. So the vast majority in the literature really haven't changed when they've been followed over years. They're uncommonly associated with symptoms, and the term annular tears shouldn't be used. There is one paper that I think I'll show here in a minute. It's coming up, I think, which suggests that annular tears in the setting of a focal protrusion may be associated with symptoms, but that's just one paper out of South Korea. Here they looked at annular fissures, and with protrusion they had an 87% positive predictive value for concordant discogram. No protrusion was not associated with a positive discogram. So this suggests that maybe these are associated with discogenic pain, but that's generally not considered the standard right now. Okay. So, well, so this was a study where they followed people over 5 years who had degenerative disc disease in a prospective study. What they found was pain was not associated with degenerative discs, and it was not associated with high intensity zone within those discs. So in this particular case, they and a lot of other people now are getting to kind of the feeling that the disc isn't the primary cause of pain in the back, that it's really other things. And that may be one of the reasons why years and years of discectomy for back pain didn't work. And there have been people that have commented on different nomenclature for degenerative disc disease. I don't use this. I don't recommend it. It's just more severe degenerative disease, and I think these terms are more confusing than they are helpful. And this is just kind of what severe degenerative disc disease looks like on MR examination, and then this is the cross-sectional, CT. Okay, so let's talk about the nomenclature that's recommended for disc herniation. So if we consider herniation, which it's hard for me to say that because for years and years, Mike Modick and Michael Bransowski and I would give lectures where we recommended patients not use the term herniation. But now that the North American Spine Society came out with this, it's kind of, I consider it the standard, though. Still, many places around the country, many academic centers do not use a standard nomenclature. And that leads still to a lot of confusion in MRI interpretation. So if you go with the North American Spine Society, herniation is defined as a localized displacement of disc material beyond the limits of the intervertebral disc. It can be generalized, greater than 180 degrees around the circumference of the disc, or localized with less than 180 degrees. And this is just kind of the localized focal disc protrusion here. We can see the nuclear material going out through the annulus. See, did you do the last one? Okay. Okay, Jason, what do you think here?
All right, we have a 39-year-old male. It's provided as extruded disc. Well, at L4 or 5, we have some extruded disc.
Okay, so we have there, here we can see this. And notice here, this is a little bit uncommon, but there are two different signal intensities. The more peripheral one here is much more hydrated than the more central one, which means that this is probably going to be nucleus pulposus material there. It comes out here, and we can see it here producing severe central stenosis. Now, one thing that this high signal material, which is very hydrated, tends to be resorbed by the body very rapidly within a couple of months. So we'll talk about a regression of disc protrusion here in a little bit. But when you see that, then that really has an extremely good prognosis. And we'll talk about papers that show that if you have an MR scan of the lumbar spine for back pain, and you look at the different MRI findings, the one, well, there are some findings that tend to portray a very good prognosis and those that are poor prognosis, and we'll come to what those are in a minute. It's not what a lot of people have thought in the past. So this would be a circumferential disc bulge. This would be a asymmetric bulging, but it's not a focal protrusion. You can also have disc herniations that go into the vertebral end plates. We saw some histology on some of these in our last lecture called Schmorl nodes. These are intervertebral disc herniations. And here's what that looks like. Here you can see the disc itself herniating into a pit in the end plate. And this is what a Schmorl node looks like under a gross section specimen. So these are really basically fractures of the end plate where you load the disc. It's too much pressure for the end plate fractures, and disc material herniates into the end plate. So it's probably an indication that you're dealing with osteoporosis. And you can see the histologic study over here with nuclear material going into it. Now, more important herniations are localized herniations. They're broad-based, which are greater than 90 but less than 180 degrees, and they're focal, less than 90 degrees. And so here would be the disc itself. This would be what they call a focal disc herniation, which is less than a quarter of the circumference of the circle. Generally, most focal herniations are going to be less than this. They're going to be really less than about an eighth. But this is the definition by the North American Spine Society. So this is a focal disc protrusion. This would be a broad-based disc protrusion. And the concept at one time was these focal protrusions might be more significant from a surgical standpoint that we'll talk about, but these broad-based protrusions really aren't surgically accessible lesions. And then there's a focal herniation.
And Campbell's does not use this nomenclature.
Okay, what does Campbell's use?
They basically define disc problems with normal bulge, protrusion, extrusion, and sequestration. That's all.
Okay. which I think is reasonable. I think a lot of these finer concepts have turned out not to be useful anyway, so that's fine. I think.
I'll agree with Campbell's.
Yeah.
They
So
had to redo this other North Society. As you remember, I brought you the first one, and you were
that's right.
interested in it, and then a couple of months later, a second one came out because they didn't agree with the first one.
Yeah, but it's pretty similar to the first one. I'm using
Well,
the
it was
same.
similar, but there was
There's some
still
changes. Right.
unsatisfactory to somebody.
Yeah. So here we can see a focal central protrusion uh, at less than 90 degrees, but in this case we still have a normal hydration of the nucleus pulposus, and that's important. And this could be an acute injury. Uh, okay, and then so a protrusion by definition, this is their definition. Basically, the disc protrusion is wider than it is deep. So if this width is greater than this distance, then it's a protrusion, not an extrusion. So if it's wider than it is, you can read, I think this is really poorly written. This comes out of the North American Spine Society paper, but it's basically wider than deep. And extrusion is deeper than it's wide. So this would be a protrusion, and this is an extrusion, where this distance supposedly is shorter than this distance. And here are actually some examples of different extrusions where you can see that it's wider out here than it in through the neck, different kinds of protrusion. And here's a nice focal disc extrusion. This is in more of a degenerative spine, but this is impressing upon the conus and producing a little bit of a compromise of the conus. Now, the next thing that you look for is whether the disc is contained or uncontained. And that has to do with whether all the disc material is contained within the outer annulus. And therefore, if you do an injection into the disc, all of your injected material will stay inside the disc and not extend outside the disc. And this is a little bit important. A little anecdote from my own example. Back when I was in Santa Barbara, California, I developed intense pain about a day after I carried some mattresses and things down into our basement. And where I really, if I were lying on my back, I couldn't even roll from side to side. It was very painful. So I was at home and they actually called the ambulance. They took me straight to the MR scanner. It was extremely painful going from the gurney of the ambulance onto the MR scanner. I got in the MR scanner and showed an acute disc extrusion, and it was not contained, which meant the nuclear material extended out beyond the edge of the annulus, out into the tissues within the spine. They actually called a pain medicine specialist who, on the MR scanner, did a steroid injection into my into the thecal sac. The pain went away in about 10 seconds. I got off the table and walked away. And I'd had a lot of back pain for 10 years before that through medical school and graduate school, probably from work I'd done with the Forest Service. And I've not had that back pain ever since that injection. So I'm not a big fan of a lot of steroid injections, but I can tell you there's one time when it was a miracle. And what's the difference? What I think the difference is it's been clearly shown that the fluid contents or the gelatin within the annulus of the nucleus pulposus is extremely irritating to tissues. It produces an intense inflammatory reactions, brings in polynuclear lymphocytes and so forth into the area with a lot of macrophages. And I think the steroid injection really stops that inflammatory process. The vast majority of people with disc herniations don't have that. They don't have the inflammatory component. It's just a direct pressure on the nerve root, and it's mostly fibrous pressure. If I had one now, it would all be fibrous because I don't have any nuclear material. So in young people where you have acute extrusions, and you see a lot of inflammatory changes in the spine. Unfortunately, I don't have my MR scan from that time. I think that injections can be extremely valuable, but probably 90% of spine injections aren't in that scenario and don't have those kind of remarkable results.
That
So,
anesthetic relaxed your muscles and took away the pain and relaxed you, John.
oh, it happened much faster, and I don't think my muscles were relaxed. I think it
Well,
directly affected the inflammatory reaction,
nerve
irritation.
impulses travel awfully fast, almost the speed of light.
Yeah, well, I think by stopping the inflammatory response, it stopped irritating the nerves, and the pain went away.
That may be true, but the cortisone takes a while to take effect. But
Oh, I think
xylocaine works very well.
I think it was the xylocaine that was effective.
Yeah, I agree.
Yeah, and so here you can see this cuts through Sharpie's fibers, but doesn't really go through the periphery of the annulus. A little bit more, you can have a partial tear of the peripheral annular fibers, and then you can have a complete tear of the annular fibers where the disc, the nucleus pulposus, is right up against the posterior longitudinal ligament, and therefore this has a direct connection now to the epidurals, well, to the soft tissues. The epidural space would be out here. So you kind of look for that.
I think what I see on that photo is some leaks through the annulus, and the leaks, if you inject them, they absorb that stuff pretty fast, and that's why I think you get the relief. Usually, I think that usually if you're going to have a success in injections, you get them right away. If you don't get a relief within a short period of time, the future is not very good.
Right, right. So the next thing you look for is migration. And this is the term the North American Spine Society recommends, and that's when the disc moves away from the site of the extrusion. So here's a focal disc extrusion. Here's a focal disc extrusion with inferior migration behind the posterior longitudinal ligament, which we can see here. And then you just measure the extent, the location, the extent here, and then you look in the axial plane to see where its location in the axial plane as well. And this is what it looks like on the gross specimen. There you can see the nuclear material coming out and herniating out through the annular tear, and in this case pressing against the spinal cord. And here's another case, chronic degenerative spine, typically, but here we can see this large extruded low signal intensity disc extrusion here with superior migration all the way up to the next disc space, with a lot of compromise of the neural canal, producing central stenosis and clumping and basically clumping of the nerve roots here. And then the final thing is a sequestration, and that's where the extruded material cuts off from its where it extruded from and is a separate fragment of meniscus. And this thought to be very important because this was thought to be something that needed to be surgically excised in the past. Now there are a number of papers show that the vast majority of these will resorb on their own. So it's no longer really considered a surgical condition when you have a sequestered disc, or at least you follow it. And we'll talk about in a minute about the differences. If you have a really extreme pain that's in the association of a disc producing nerve root compression, then the pain will be relieved more rapidly if you have surgery. But at 1 year, there's no difference between whether you have surgery or not, because all of these discs that are going to produce symptoms on the nerves will resorb on their own, usually in 6 to 9 months. But if you can't control the pain, that may be an indication for surgery. And this just shows the sequestered disc here. Okay, who's next? I think Robert?
So we got a couple sagittal images here of this spine. Looks like there's some looks like extruded material into the spinal canal.
See, there's a distribution there, but it's this funny thing back here.
Yeah, it's gonna be sequestered fragment.
Okay. So, yeah, what's this thing there? Where the axial images, this is what the T1 looks like. Here's what the T2 looks like. What's happening here?
So it looks like there's again some disc material in that spinal canal on the right.
So what we have here is we have central stenosis. We have a paucity of CSF surrounding the nerve roots. We'll talk about how to grade central stenosis later. We have a focal disc protrusion here, and this is a sequestered disc back here, which is further compressing the neural canal at this location. So that's a little sequestered disc. Okay. And here we can see another disc extrusion with a sequestered disc down here, valve level. This has a little bit of increased signal intensity. These tend to absorb pretty rapidly, so they're usually just watched unless you can't control the pain in this day and age. Now, if we go to the North American Spine Society, also has discussion of central stenosis, where they can talk about volume and the compromise. Mild would be less than a third of the volume, compromise, moderate between a third and 2/3, and severe greater than 2/3. But what's really important here is not the percentage. Some people have very large canals, and if you had half of it compromised, it's not going to be very significant. Other people have congenitally small canals. So what's really important is how much CSF there is around the nerve roots. That's really what you should look for to determine whether it's mild, moderate to severe, in my opinion. And then you need, if it's focal, you need to talk about the location of it and the superior inferior areas. You talk about the suprapedicle level, the level of the pedicle itself, the infrapedicle level, and this would be the disc level. So those are the nomenclature used to determine the level. So if you had a sequestered disc up in this area compressing the nerve root, it would be at the pedicle level. Okay. And then in the axial plane, there's central zone, subarticular zone, foraminal zone, and the extraforaminal zone. That's what they recommend. Now, in the radiology literature, most of the time it's central, lateral recess, which is this area in here, pedicle zone, which is this area there, and the far lateral zone out here. So the North American Spine Society suggests central, subarticular, because that's what the surgeon can see, because when you get in there surgically, you can see where the articular surfaces are for the facet joints, and it's easier to evaluate where the subarticular zone is below that, and then the foraminal zone, and then the extraforaminal zone. And then again, here's just looking at the different levels again, the nomenclature to use. So already saw this area of central focal protrusion, and here we can see a focal extrusion, and this would be central, and then the subarticular zone, and we can see that it butts the transiting left nerve roots here, probably the L5 nerve root here, and with probably a little bit of lateral deviation in this area. So that's kind of what you described. Notice that there's increased signal intensity within the disc extrusion here. So in my experience, this tends to resorb pretty rapidly. And most of these now are followed. But when I first went into practice, when we first started doing MRI of the lumbar spine, these were all considered surgical lesions. Okay, Elliot.
Okay, so sagittal T2 views of the spine. Looking at L3-4, we see, okay, on
That's the old clean film days.
Yeah. In 2003, that disc didn't look too bad, but then the next year, looks like there's a protrusion with some annular fissuring.
Okay, this is actually post-contrast, showing a little enhancement of that.
Yeah.
And this patient had not had surgery. Okay, so this is a local protrusion with contrast enhancement. Okay. Okay,
Right.
it's a professional hockey player.
L5 radiculopathy. Okay. So looking at this T2 sagittal view of the lumbar spine, we have this desiccation at L45, L5S1. At L45, we have it's like a central slash subarticular extrusion.
Yeah, extrusion with a little bit of inferior migration
Yeah.
here. Okay.
And I think it does contact the traversing L4
So
root
probably
right there.
posteriorly displaces them a little bit here
Yeah.
and produces a little bit of lateral recess stenosis on that side. Okay. Oops. Okay, so this is 11/23/09. He continued to try to play professional hockey, came back with severe pain and where he couldn't play anymore, and this is what it looked like. And we're just talking about like 2 weeks later.
Okay, so it looks like he ended up sequestering that fragment.
Right. So you can see there's a little bit more loss. There's a little bit more loss of height here. And now we can see that the protrusion here, but we can see the bulk of the extrusion we saw before is now a sequestered disc, separated there. Exactly. And this is what it looks like. This was before, and now after that nucleus pulposus has extruded out, it's become a little bit more hydrated and therefore higher in signal intensity. And we can see it here in the lateral recess, producing a lot more lateral recess compromise and compression of these transiting nerve roots here. That's 12/4/09. Okay. Okay, I think later we continue to follow him for another couple of eventful months, but I think that will be later in this lecture when we see what happens after this. And this is just some study, an early 3T image showing disc extrusions on a early 3T scanner. Okay. All right. Robert, what do you think here?
So we have sagittals and axials. Looks, I see another disc extrusion. Yeah, right there.
You can see it here, producing a lot of lateral recess stenosis, a lot of migration, and it's really in the subarticular zone predominantly, a little bit in the mid zone. Okay, Elior, what is going on here?
Okay, so on the left, an MR at L45 looks like this dark material, possibly from the disc space, protruding into the spinal canal. On the CT, it looks, it looks ossified.
Right. It comes in here, the axial images. So that's a calcified disc extrusion. I haven't seen these very often in the lumbar spine. I've seen a few in the thoracic spine, but these obviously are chronic. And to be chronic like this has really got to be most of the fibrous material from the disc has extruded out there because all of the nuclear material would have been resorbed.
Well, they're operated on, John. That's why you don't see them.
Okay. And then here we can see that it's common to get calcification within the discs. As we can see here, when you have degenerative discs. Okay, let's see.
All right, so looks like in the left no foramen we have some disc material.
Is it mass or is it a disc? Here is what the sagittal images look like. This is T2 and this is a post-contrast T1. Pre-contrast, post-contrast T1. So yeah, you're right. This was a disc extrusion out in that area. And very commonly when you have disc extrusions like this, you'll get a little enhancement of the granulation tissue around
I
it.
see. Okay.
Yeah, that's pretty common appearance back. And we used to give a lot of post-contrast after surgery looking for disc fragments like this that might have been left behind at surgery and this is a typical appearance of that. And as we'll see in a minute, if you have these little disc fragments, they actually don't change the prognosis of the patient. So most of these aren't considered surgical anymore. And here's another extrusion. This is going into the foraminal zone. Here's a disc down here compressing the nerve that's pushed up to the superior part. And here is the foraminal zone disc protrusion. And these are important, as we'll see in a minute. Or maybe next week in our next lecture, we don't really have any really great big studies correlating surgical and MR findings with basic patient symptoms or outcomes. It's unfortunate that we don't. But of the smaller studies that we have, the one finding that seems to be reliable is acute foraminal zone protrusion do produce radiculopathy due to compression of the nerve. And that's what we're seeing in this particular patient. And you can have far lateral disc extrusions as well, like we're seeing here, a more degenerated disc called extraforaminal or far lateral. And then here's another far lateral extraforaminal disc protrusion. And with contrast, you can see this patient had not had surgery. This is just the granulation tissue that's irritated around the disc protrusion, enhancing with contrast. And here's another far lateral protrusion. This is the sort of protrusion you would see in people who have prior discograms. Okay, right. Robert.
All right, so a couple more sagittal MRs. Looks like L4-5. There might be some disc material in that. Yep.
So whatever you do, spines, you really need, I think, to look at the T1 weighted images in the sagittal plane and look at the foramina and make sure that the fat within the foramina are all symmetric at all levels. Here we clearly have loss of the fat on the inferior part of the neural canal. On the axial images, we could see this disc protruding here into the foraminal zone and far lateral zone with root edema. Okay. This is a patient, these are post-contrast images. What are you seeing here?
So, okay, at L5S1, maybe there's some, I see some protruding or extruding disc.
So there's a little retrolisthesis here
Uh-huh.
and a little uncovering of the disc back here, which is protruding out. What do you think that thing is?
Is that just the phylum terminal or is that compressed nerve roots?
So this is actually an enhancing nerve root
Okay.
coming down through here. And there you see the focal enhancement. It's not on the other side, just this side. So what's the significance of this? Notice it's enlarged down here inferiorly. There was a time when we thought this might be an indication of pain. So that was another reason why people for a while did post-contrast imaging to look for enhancing nerve roots. But the bottom line is maybe due to blood-brain barrier, maybe due to inflammation, but it doesn't really seem to associate much with symptoms. So it's probably not a significant finding anymore.
All right, so sagittal T2 of the L spine. There's a extruded disc material at L5S1 with inferior migration.
Okay, everyone's coming down here. And this is post-contrast. Notice that extruded material is actually enhancing with contrast. And that's the other thing that we find is actual extruded disc itself can actually enhance, especially if it's been there for a while and you start getting an inflammatory reaction that's then responsible for resorbing the disc. Then it can enhance because it become vascular. So contrast is not that great differentiating granulation tissue from actual disc material because of that. Okay. Why don't we stop here? And there's another finding that we'll talk about on Monday. Okay?
All right. Sounds good. Oops.
Have a happy weekend.
All right, you too.
Thanks, John.